Oh. Okay. Good morning, everybody. First, I'd like to congratulate Fertility Planit for organizing such a fantastic and informative show. My name is Dr. Milan Yao, the co-founder and CEO of Unify Inc., the IVF prediction test company. At Unify, we use advanced statistics and research to provide online, personalized prediction of IVF success. If you are considering IVF for the first time, please look at our Unify pre-IVF test. If you've had IVF before and are considering doing another IVF cycle, please check out the Unify Predict IVF test. Both tests will use your personal reproductive health profile to calculate your personalized chances of having a baby with IVF. Both tests are available at our website, www.unify.com. I feel very privileged to represent Unify today in sponsoring this very exciting session. In Vitro Fertilization, Factors for Success and Issues Related to Failure. I'd like to introduce Liz Silverman Platt, who is the moderator of this show.
Thank you.
Liz has over 7 years of personal experience in the field of infertility. Liz is a former intended parent herself. She struggled with infertility for 5 long years and then had her twin boys through a wonderful and dedicated surrogate. Through her own challenges with infertility, Liz became inspired to help other women who are also on the journey of IVF, egg donation, and surrogacy. Liz is the principal at Baby Steps Fertility, a consultancy service that is the intended parent's complete resource from inception to conception, and for all the challenges in between. At Baby Steps Fertility, Liz accesses the necessary resources, including physicians, agencies, and attorneys, to match clients with their egg donors and surrogates. She is very experienced, savvy, and committed in guiding intended parents to create a family. Liz.
Say anything, because that was a wonderful introduction. Thank you to Milan and to Unify for sponsoring and making this panel possible. And indeed, as was just stated, I am a former IVF patient and intended parent. My husband Michael's in the room, and he can attest to everything that I'm going to say. We went through 5 very, very long, hard years of infertility. It included 8 IVF cycles for myself, 5 of them utilizing my own eggs, and then 3 of them with egg donor eggs. Unfortunately, there was never a pregnancy. It wasn't a case where I was miscarrying. There was never any implantation with my transfers. So after enduring those 8 long cycles, which also consisted of consulting with 8 different doctors, I had every test, biopsy that you could think of under the sun. And in the end, we had a fabulous and wonderful surrogate carry and deliver my twin boys, who are now 3.5 years old. And they're an absolute blessing, and sort of everything fell away, and you don't forget about your journey, but you are so blessed, and you're so happy, and you move forward, no matter what we went through, no matter how much money we had to spend, which did develop into the hundreds of thousands of dollars, unfortunately. We're blessed with 2 boys who are just the source of inspiration and our lives. So early on in my process, I realized that I recognized that there was a void as it related to us, the intended parents, and the people going through this. The physicians are wonderful, the agencies are wonderful, everyone's wonderful involved in the process, but there are so many steps along the way and so much trial and tribulation that you can experience. I just felt like after the 3rd failed pregnancy test, it was, what do we do now? After the 4th, 5th, what do we do now? The only way that I could get through it was to have a next step, and so that was how we survived what we went through. I couldn't just sit and sort of wait the 2 weeks for the hormones to leave my body and to just sort of settle into it. I had to have a plan and move into that plan of action immediately. So I developed Baby Steps Fertility. It's, as we said, it's a service designed solely for people in this room going through the journey of infertility. I sit with clients, I find out what they're all about, I educate on IVF, egg donation, and surrogacy. I refer to fabulous physicians, do some very hardcore profiling, diligent profiling of my clients to their egg donor, future egg donor or surrogate, and then I'm involved from beginning to end, orchestrating that process for them. It's January, mid-January of 2013, and there are 6 babies already on their way because of my assistance, and what that does for me is you can't describe. So that's what Baby Steps Fertility is. I'm thrilled and honored to be here and to be moderating a panel of esteemed professionals who will have an opportunity to sit and discuss what they do. Before I get into some introductions, I did want to say a couple things. This is Fertility Planet's first year. It's phenomenal that in addition to the attendance that we have here, there are thousands and thousands of people online via Facebook and Twitter who are signed in, logging in, following all day long. So I urge 2 things. Everybody in the room to please, when you're not in session, go to the exhibit hall, ask your questions. Actually, this relates back. Empower yourself as a patient, as an intended parent. Ask your questions, become educated. Don't be shy when you're sitting in with your doctor. Don't be shy when you're talking to an agency about a donor or a surrogate. Ask everything you need to know, because you're the one that's going to be in control of your journey with a professional. So visit the booths, visit the exhibitors, ask your questions. Online folks, please follow us all day long via Twitter, via Facebook. I want to mention, excuse me one second, while the hashtag via Twitter, for Twitter, is #fertility and then FPS13. That's enough about me. At this time, I'd like to sort of give my introductions, if I may. Right next to me, we'll start with Dr. Jeffrey Nelson. Dr. Jeffrey Nelson is a reproductive endocrinologist with HRC, which is Huntington Reproductive Center in Pasadena. If I'm not mistaken, HRC has 8 offices throughout Southern California?
We have 9.
9, okay.
We have a brand new one.
There we go. Oh, which I didn't even know about. So this is Dr. Jeffrey Nelson. Then we move over to Dr. Mark Surrey, who is medical director and co-founder of Southern California Reproductive Center, also known as SCRC. Dr. Surrey is also a clinical professor at UCLA and the co-director, you'll have to help me out here, Reproductive Endocrine Fellowship? Not exactly.
The training program.
Training
for
program.
the doctors there, yes.
Which he will also further explain. And then we have Alisa Vitti, who is founder and CEO of Flo Living out of New York. And Flo Living is a functional nutrition platform, online platform, for hormone and reproductive health. Dr. Nelson?
My turn?
Your turn?
Okay.
Yeah.
My name is Dr. Jeffrey Nelson, and I am also a fertility specialist. And my medical practice is Huntington Reproductive Center. My office is in Pasadena. HRC was founded back in 1988, so we're now celebrating our 25th anniversary. I am the 3rd member to join the practice. I joined the practice in 1992, and 2 of the founders have since moved on, and so consequently I'm presently the longest standing member of the practice. I've been there for about 21 years, and we have had a lot of changes over the last 25 years, but a little more with me. I happen to grow up in Michigan. I'm a Midwesterner. I went to Texas to go to medical school, and after medical school I went back to Michigan, did my internship and residency, which was in obstetrics and gynecology. I then moved on to Philadelphia, Pennsylvania, and did my fellowship in reproductive endocrinology and fertility at Pennsylvania Hospital, which is kind of a unique place. It's the nation's first hospital. It was founded by Benjamin Franklin and Thomas Penn. But then I moved back to Pasadena. I moved to Pasadena in 1992 to join HRC. And over the past 25 years, as was mentioned, we started really with 1 practice, and we now have 9 offices. We started out with 2 physicians, now we have 11. We had 1 IVF lab, now we have 3. And so we've just kind of grown over time to progressively become the largest practice on the West Coast, and we're about the 4th largest practice in the country. We're internationally known. Our practice is really clinically and research oriented. And really, basically, for the past 25 years, we've just been trying to serve patients in Los Angeles, Southern California, really across the country and around the world, just helping them to achieve their goal of having a family.
Dr.
That's
Surrey?
it?
Yeah, Dr. Surrey.
I'm Mark Surrey, and I'm from Maryland. Did my medical school and undergraduate training in the DC area, and looked outside when it was time to match for a residency, and it was sleeting and 38 degrees, and decided to come out here, and haven't regretted it since then. Did my residency training here in both OBGYN and general surgery, and fellowship training in the University of London. And it was an exciting time because we were starting something at that time that became sort of state of the art now with in vitro fertilization, which began in Cambridge, England, prior to my going there with a gentleman named Patrick Steptoe and Robert Edwards. And it really has revolutionized our whole field of medicine. And the technologies that we're going to speak about, I think, a little bit here this morning is a reflection of what has evolved over these last 30 years in this field, because it gives us an ability to diagnose and treat problems that we previously hadn't been able to do. Like Dr. Nelson, I'm in a group practice. We have perhaps a little smaller group. There's 6 physicians and 4 different offices and 2 PhD, 3 PhD embryologists. We are presently have labs in Los Angeles, just down the street here in the Beverly Hills area, and now up the coast in Santa Barbara. And we feel that we really enjoy taking care of patients by providing what we feel is the optimal environment in which to do so, whereby we have both diagnostic medical capabilities, surgical capabilities, and a top IVF lab run by a couple of the best PhDs in the country that utilize technology that allows us to help people. And one of the things we're going to chat about a little bit this morning is, I think, how this whole technology allows us to define certain objective aspects of fertility. As you all know, I'm sure there are lots of subjective aspects of it, the way we feel about it, the way that, what we were alluding to, I think, with the journey. And, I think we now have technology that is fairly clear enough to enable us to be more efficient with this and to shorten this journey. Now, when we do that, it allows us to provide patients with the knowledge from which they can then choose how they would like to become parents. But, there are different ways to do that, and, it's one way may not be for everybody, but the technology that has evolved with this field of in vitro fertilization, I think, allows us to define fertility for a couple. And in doing so, it allows them to become empowered with information upon which they can then choose which is the best, path for them to go by. So, I don't know, are we going to chat formally about any of these things, or just informally? In other words, are we going to... I'm going to pose some questions to the panel, and then we're going to open it up, actually, to the audience to go and do their questions. Well, perhaps if you want to maybe, there are just a couple of things that... now's a good time. Maybe we can just use as a basis for the discussions. One of the main problems that we see with couples is and this is a fact, it's not an opinion, but fertility declines as we age as human beings. And it's really never a guarantee, no matter how young and healthy we are. So if you look at a per cycle delivery rate for normal physiology, this is kind of what it looks like. So when you're on the edge of a lady who is in her 40s trying to conceive using her eggs, you know, the normal chances are low. So when you look at what can we do with technology, we can sometimes improve those chances and sometimes we can't. But we can define them. So this is, again, just a population statistic, but it gives you kind of an idea of what the facts are. You go ahead with the next one. And one of the reasons why we see this has to do with the genetic content of the embryo that causes a pregnancy. And as human beings, we're kind of flawed in this regard. And when we look at genetic content of human embryos, they're usually never 100% normal. When we look at this with egg donors, 21, 22, 23-year-olds, probably 1 in 5, 1 in 4 of their embryos are not normal. So this is something that actually becomes a very significant impediment to fertility as we age. And so when we get into our 40s, if you look at just you know, this kind of data, this is really one extreme. In other words, these are pregnancies that have actually occurred. The most common consequence of an abnormal embryo genetically is that it won't cause a pregnancy at all, or it'll cause an early miscarriage. So we now have the technology to actually look at this before a person has an embryo transfer. And this is data from a new study that we're publishing over the next couple of months in a journal that shows, and I don't have a little pointer or anything, but the bottom line is that if you look at human embryos genetically, which we now can do in an IVF laboratory, we find that a significant proportion of them are not going to be normal. The testing we've figured out how to do accurately and without adversely affecting the ability of the embryo to cause a pregnancy. So it empowers the patient and the doctor with information that you otherwise would not have. So, for example, when you perhaps are an older parent and you go down this long path and are doing things, perhaps taking medications, maybe doing inseminations, you know, if the embryo that you're creating is not genetically normal, it's not going to cause a normal pregnancy. Now, there's sort of a normal algorithm that you go through. Everybody wants to conceive naturally, and that's great when it happens. But usually, people see us when that hasn't happened. So what we want to do is explain to people, firstly, why it's not happening, if we can figure this out, and then give them treatment options. This information that we can get from testing embryos genetically now is very powerful. Now, you know, it's like asking a question. Sometimes you like the answer and sometimes you don't, but at least you get the answer. So if the answer is that you have a genetically normal embryo to transfer, this actually allows us to give that patient, who may be older, a very high rate of implantation and a very good pregnancy rate. If the embryo is not normal genetically, you're not going to get pregnant normally. So what's the point in pursuing that? So, you know, again, it gives us information, and we give the patient the information, and then you do with that what you'd like. And it may be that, again, the information is not what you like. Maybe you don't have normal embryos. Well, if you don't have normal embryos, the idea of going down this path with this journey of month after month after month of trying, you know, may not be productive and probably is not going to be. So you could take all that time, all those resources and all that energy and you know, focus it in a different direction, perhaps, that is going to be productive. So again, I think this technology unfortunately doesn't allow us at this stage to change the answer from giving you a normal embryo if you don't have one. And maybe in the future that will be possible, but today it's not. And it's information, and I think information empowers bright, motivated people to be able to make more informed decisions.
Thank you, Dr. Surrey.
Sure.
Alisa.
Hi, I'm Alisa Vitti. I'm the founder and director of FloLiving.com. We're the first online hormonal improvement platform in the world. We actually serve patients in 6 continents. And we help women who are going through the IVF process to use food in a functional way to improve their hormonal balance and to improve the IVF process. So my background is that I come from Hopkins. I was on my way to becoming an OBGYN when I myself had a hormonal breakdown. I was struggling, if you can imagine me 15 years ago, 200 pounds, covered face, chest, and back, and cystic acne, and menstruating once a year. I was struggling with a condition that some women who are dealing with infertility may know of as polycystic ovarian syndrome. And I happened to be studying some of the really interesting things that were coming out of the Human Genome Project, specifically around nutritional genomics. And I got really excited about what we were finding in terms of influencing gene expression with using food and lifestyle approaches, which in fact are the only 2 things that we know affect epigenetic expression in a human being. So I got really excited and I thought, what could I do to change my hormonal destiny? And how could I use food to do that in a very specific, replicable way? And so this protocol that I designed over 10 years ago, I've had the opportunity to share with women all over the country, all over the world for the past 10 years. And then this year we launched this first ever platform in March called the Hormonal Sync System, which many IVF doctors prescribe to their patients either prior to going through the IVF process or during, to help increase the likelihood that the IVF round will be successful. Because as Dr. Surrey was saying, we want to feel like we're empowered with the right information to do everything we can to improve our chances. And we have now such great clinical data on what food can do in terms of affecting outcomes. And it is imperative that if you are going to be going through this journey, that you take your diet seriously. So it's exciting that we are now able to really look very specifically with data at what food can do for your reproductive outcomes. So happy to be here and happy to answer your questions soon.
It's amazing. So what I'd like to do is actually pose some specific questions to the panelists, and then we are going to open it up and answer your great questions. So to Dr. Surrey, when a patient comes to you after having trouble conceiving, how do you determine whether it's time to try IVF? What are the factors that you look at to let them know what their chances are for success? You can elaborate on the slides, I'm sure.
Sure. Well, I think the first part of that question is when do we get into this technology? And, if you come in with the question, what is the quickest approach for me to diagnose and treat my situation, assisted technology now is. However, there are certain algorithms that we like to use based upon a patient's age, their medical history, as to what other alternatives there might be first. It's interesting that this whole technology used to be considered sort of the last stand, the last step. And that's mostly because it didn't work very well 20 years ago. It works much better now. We have more tools now to use. So we tend to get into it earlier in the treatment process. But again, it depends upon the patient. Medicine is actually sort of an art, even though it is a science. And this particular field of medicine illustrates why it's an art. Everybody's different. There aren't any actual specific algorithms to determine the answer to your question for many patients. Now, there are some patients, clearly, in whom in vitro fertilization is the only choice, and that's based upon things that we, see sometimes. such as, for example, you guys probably know normal fertility occurs in the human fallopian tube. That's where fertilization occurs. So if the fallopian tube is irreversibly damaged by an infection, surgically removed, then it becomes clear that this technology of in vitro fertilization is the only approach. Certain other issues, for example, with a man's sperm, can make it the only approach. There's a process whereby we can inject individual sperm into an egg, and so if a man has, for example, undergone a vasectomy and has a small number of sperm to aspirate, this becomes sort of probably the only approach. But the majority of the patients that we see kind of evolve into in vitro fertilization because other things aren't working, because they're compromised in terms of their fertility by other issues. For example, if we see a typical patient of ours who is now almost 40 years of age, who comes in with a history of recurrent endometriosis. I don't know if you guys know what that is, but it's a pretty common problem that is a reflection of sort of ectopic or abnormal growths of the lining cells of the uterus called endometrium. And it adversely affects fertility in lots of different ways, some we don't even know about, but it seems like this technology, in vitro fertilization, can often enable patients with this problem to conceive more quickly. So I'm going to give you an anecdotal answer to your question because it's different for everybody. If we see a 40-year-old who's had 2 laparoscopies at age 36 and age 38 for advanced stage endometriosis, her fallopian tubes are open, her husband is normal, everything else is fine, she's ovulating, we kind of get the sense that maybe that's the reason why she's here. She's got more endometriosis. So yeah, we could do another laparoscopy and give her a few months of medications and try inseminations, but in that particular patient, then she's going to be 41 or 42. And I think, again, time is really a precious commodity that none of us really have enough of. And so in that particular patient, we'd be much quicker to advise that she get into in vitro fertilization than in somebody who didn't have that history. So it's a long way to say there isn't an answer to your question, but everybody's different.
Understood. In the interest of our time, we absolutely want to make sure that we can have you guys ask your questions. So if it's okay, we're going to go to the audience, and then we can come back to our other 2 specific questions that we have for Alisa and for Dr. Nelson. Questions?
I was wondering if you could advise me on, I've gone to 3 different IVF doctors, and each time it seems like starting from square one as far as what medications to try, and it seems like I feel like a guinea pig each time I go to a new doctor. That doesn't seem as if they learn from the previous doctor's tries.
Opinions are like noses. Everybody has one. Again, there is somewhat of an art to practicing medicine. I may do things a little differently than another doctor, and Dr. Nelson may do things a little differently than I, so it really is dependent upon who you are and what the situation may be, but clearly there are, you're right, there's information you should be able to glean from your history, and your doctor who is looking at another doctor's records of how you got there, how you responded to their treatment, what your laboratory results were, should be able to hopefully learn something from that. So from the perspective of starting over again, which is what I think your comment was, It is also true, however, that different doctors, different practices, different laboratories, have different ways of doing things. They're not all the same. It would be nice to be able to know that everything is precisely identical and standardized in our field. And we're always looking to try to do that, frankly. We have meetings, all of us, on a regular basis. We publish things. We, compare results. And we really try to do what's best for you guys by learning from one another and trying to make things standard. But it's not quite black and white.
Thank you so much, Dr. Surrey. We've got a question here, and then I know we have some in the front as well.
Hi, I'm 44 and never been pregnant before. My doctor says I have young ovaries of a 40-year-old, but I guess that doesn't mean that my eggs are that young necessarily. So we're struggling with the idea of maybe doing IVF or IVF with donor egg. And so what advice would you give me? Should we just not even think about IVF with my own eggs, just go straight to donor in terms of the health of the baby and the chances of success?
Me or Dr. Nelson?
Yeah. It actually, since Dr. I'm sorry to interrupt. Since Dr. Nelson's question was actually geared towards moving forward to egg donation or such, would you answer that question for us?
Sure.
Thank
Well,
you.
do you want me to answer? Do you want me to address
No,
that?
I'd like you to directly
Okay.
to the question. Thank
So you're
you.
44? I mean, I know without question the most efficient way to get pregnant for you is going to be through the higher technologies with IVF. Then the question becomes, of course, do you use your own eggs, do you use the eggs of a donor? And I just know in our program, in our program, there's obviously, like every program, there's a declining chance of conception with advancing female age. And at HRC, people that are 41 and over, the overall rate of pregnancy is about 20%. However, there's a lot of people that are way beyond that 41. So 41 and 42-year-olds tend to bring that curve up a bit. They're about a 30% pregnancy rate. 43 and beyond, though, they have a pretty precipitous drop. And so realistically, there's probably no better and probably less than a 5% chance conceiving with your own eggs. And so the question then becomes, is it worth going through all the things that are required, all the costs of an IVF cycle to you, physically, financially, and emotionally? Are those costs worth going through knowing there's this certain chance of an outcome? Some people would say, absolutely, because some people actually need closure. They need closure based upon a failed cycle, a canceled cycle due to poor response, to allow them to move on to the other technologies like egg donation. But if you're looking for, just being very pragmatic and trying to figure out the best way to use your resources, without question, your chance of conceiving is going to be much higher by using a younger egg.
Thank you.
Hi, this question is for Dr. Surrey. I'm going to actually be 34 next month. And
I'm sorry, how old?
34.
Uh-huh.
And I suffer from kidney failure. And I was wondering how IVF plays a part, or if you guys have worked or currently are working with any patients who have struggled with what I'm going through, and how the IVF procedure affects that whole realm of things.
The question had to do with a medical issue involving renal or kidney dysfunction or failure. It's really a two-pronged question, if you will. One is, and the first and I think most important part of that question is should you be carrying a pregnancy? Okay. So then, given that, because a pregnancy, as you guys may know, is...
Sorry, Dr. Surrey, can you just say, did you... She answered a question the live audience can't hear. Would she be carrying the child?
Okay, the answer is no.
Okay, so that changes things.
So the process of in vitro fertilization in your situation brings in what's called gestational surrogacy. So you're going to have a surrogate, and by definition, a surrogate will hopefully be the best possible place, because as you guys know, I think a surrogate does not contribute to the genetics of the pregnancy. A surrogate is just a place for a pregnancy to grow. And as such, we want to firstly screen the surrogate to be sure that it is going to be the best place by doing some testing of her uterus, and so forth. So let's assume that you've done that. And then the question becomes stimulating your ovaries and removing your eggs for the in vitro fertilization process. Is your renal status going to be affected by that, or is that going to affect your ability to stimulate? And the answer is that your renal status may affect the way in which you excrete some of the hormones and the effectiveness of the hormones. And I don't know anything about your general endocrine or hormonal balance, but for example, people with renal dysfunction may have a higher incidence of what's called ovarian stimulation, hyperstimulation. That would be where there is fluid that's actually a protein. It's sort of acidic fluid that builds up in the abdomen. And so your stimulation, depending upon your hormone levels, needs to address that as a potential, and perhaps might be a little slower, a little bit lower, and require more monitoring than someone with, normal renal function. But in and of itself, you should be able to hopefully be stimulated and monitored and create a pregnancy. Sure.
Another question right over here.
Hi, can you talk a little bit about diminished ovarian reserve and being a poor responder and how that relates to success and failure? And if there are any, nutritional pointers or anything. I'm 32, I've had a failed cycle because I had nothing to transfer back in, and I've been diagnosed with being as a poor responder and diminished ovarian reserve, and I'm confused if it's sort of the same thing and trying to decide whether or not to do this whole thing all over again.
Is that for Alisa?
Sure. I think it's important, to appreciate that you're still young and that there's always an opportunity for you to look at, from the endocrine system as a whole, what might be going on to inhibit ovulation and menstruation. So it would be interesting to have you be looking at which foods could actually start to bring more blood flow to the ovary, which could help you with estrogen and progesterone balance. For example, things like turmeric have been studied. The active compound in turmeric, curcumin, has been shown to improve the vascular health of the ovary. So taking a turmeric supplement could be something that's really, really beneficial for you. Also using foods that are naturally phytoestrogenic or phytoprogesterone, have rich reserves of phytoprogesterone could be beneficial. Things like egg yolks, which are naturally rich in phytoprogesterone, or soy, which is naturally rich in phytoestrogen, can be beneficial in helping with those levels. So, we see a lot of women coming in with premature ovarian failure, and we really can guide them through a process where they are nutritionally supporting the endocrine system as a whole to get it to reboot. So, again, because you're 32, I would say it's worth giving that a try, in addition to whatever medical support you may be getting from the IVF process.
Thank you.
Would you like a medical answer to that question, too? We look at a lot of things when people come in for evaluation to see what we think the response to medications are going to be, including your age, consistency of your menstrual cycles, hormonal levels like an FSH level, estrogen level, things called anti-Mullerian hormone inhibin B. We also look with an ultrasound to determine how many little follicles we call antral or resting follicles are present on your ovaries. Those all help us to determine what we think your response to medication is going to be. It sounds like you've already been there. They've tried, and they haven't been very successful. And so, the key thing to me would be to review records, to look at what protocol was utilized for your stimulation, to see if maybe alternatives could be utilized in order to maybe try to improve your response. I'm kind of a believer in certain augmentative things too, and potentially looking into Eastern medicine. I think that they just approach you from a whole different paradigm than we do, even with how they diagnose and how they treat. I think it has the power to be one of the most synergistic things that you can do as long as it's in the right hands. A lot of the Eastern medicine folks, it's kind of like apples and oranges comparing. They're different. So it's important for your infertility specialist to have people he's comfortable utilizing so those two folks can know best how to collaborate for your care. So the bottom line is I don't think you should give up on that. I think it's important to have records reviewed and see what maybe could be done differently to get a better response.
Thank you.
Okay, my name is Irina Gershman. I'm an acupuncture doctor. Thank you. Actually, I compliment you for this wonderful mention, acupuncture. But my question is a little bit different. You know, because I'm doing it for many years now, I have a tendency of the women who are coming for the second or third child. And they already went through IVF treatment. They were very successful. They get there. They achieve their goal, they have a first child, and they coming to me and they say, oh, second time I want to try without IVF, I want to try naturally. And I never read anything about, I don't know what my strategy, what my tactics should be about these women. Does the previous IVF treatment, does it increase ability of the second pregnancy, or there is no any influence? Because they asked me that they were going through the treatment, they were going through the very abundant treatment with hormones and everything. Does it increase the ability of the body to be pregnant second or even third time? Or there is absolutely no any chance, and I should say, go to your fertility doctor, that I normally do.
Well, it's a complex question, it's a complex answer, but I think to try to simplify it as best we can, does perhaps, despite utilizing in vitro fertilization technology for one pregnancy, does the fact that the patient has delivered make it easier for her to deliver again, perhaps without this technology? And, you know, the answer is it might. But it depends upon, again, the individual. If the patient's not getting pregnant initially, and what was her first reason for doing IVF, and for example, if it is a clear recurrent reason, like dysfunctional fallopian tubes or something like that, then it's not going to matter. She's going to have to do IVF again. If, however, there are a lot of patients in what we call a category of sort of unexplained infertility. And these are the patients who, you know, may well benefit from being pregnant, having a delivery. A lot of these patients are not going to have to do IVF again. And I think you're absolutely right. It's certainly the doctor and yourselves, and, you know, we should all, I think, take a fresh new look at the patient after a delivery. People change, you know. Depends upon when the delivery was, you know, if it was a year ago, if it was 10 years ago. So I think you have to start over again, basically.
Excuse me for 1 second. I know we have more questions. We're going to go to online. I urge you, everyone will hang for a few minutes or so. If we definitely want to make sure we get your questions answered. So if we can go online now.
Sure, absolutely. Thank you. Let's see, we've got a lot of interest in this topic online as well. Actually, a patient of Dr. Nelson's who said they had a really great experience with Dr. Nelson, but said that they wanted to hear about recurring miscarriages. They say it seems like they don't talk about it because it's such a medical mystery. So I think this is probably posed to everyone on the panel, but perhaps Dr. Nelson, since this person had a good experience, you could answer?
So on recurrent pregnancy loss.
Yeah, recurrent pregnancy loss and what that means, why it's not talked about much.
Okay. I mean, it's a fairly big part of our practice, so just because of our niche, we see a lot of that. So we talk about it a lot. And we, you know, it used to be, and maybe in some clinics still, when patients have had 3 consecutive losses in a row, that used to be termed recurrent pregnancy loss. Now we do see a bit of an increased risk of a pregnancy loss after someone's had 2 consecutive losses. So we personally will start to investigate after 2 pregnancy losses, 2 first trimester pregnancy losses, pregnancies less than 12 weeks. And there's a certain category of things that you can look into for that particular patient population. And so number 1, they have to have normal uterine anatomy. Some patients are born with things we call congenital uterine malformations, where they have half a uterus or a double uterus or a large septum coming down the middle of the uterus. Those things don't typically diminish the chance of conceiving, but they do increase the risk of pregnancy loss. So there can be uterine anatomic things. If the uterus was designed normally, there can be things that develop over time. And sometimes there can be fibroids. You probably heard that term before, but muscular growths within the wall of the uterus that can sometimes impinge or compress and deviate the cavity itself, or overgrowth of the lining of the uterus called endometrial polyps. Those can also potentially diminish the risk of implantation and create fertility issues, as well as increase the risk of pregnancy loss. So you have to have normal uterine anatomy, and that can be assessed through a variety of techniques. The second thing is sometimes patients, well, when patients ovulate, they're supposed to make the hormone progesterone, which tends to peak about a week after ovulation, which develops a lining of the uterus appropriately for implantation of an embryo. And some women don't make adequate levels of progesterone, either the height of the production or the duration. And so they have inappropriate endometrial development or implantation and increased risk of pregnancy loss. And so there's tests that can be designed to look for these things that we call luteal phase defect. Some patients will have blood factors that can increase the risk of blood clots developing new little placental blood vessels. And the two things we look for are potential antibodies that are produced called anti-phospholipid antibodies, which we can determine through a blood test. There's also some new genetic information, sometimes on little genes that code for proteins that are involved in the coagulation system. Those genes can have mutations. The mutations diminish the production of the particular protein, or it doesn't work as good as it should. And those proteins in the coagulation system, when they don't work right, also promote blood clot formation in newly developing blood vessels like in the placenta. So blood work can be done to look for those things. That's the third thing. Those can be treated by giving someone a baby aspirin a day and also a low dose of an anticoagulant, either heparin or Lovenox. So there's uterine anatomy, there's low progesterone levels, there's abnormal things that cause blood clots in your system. One of the more common reasons for pregnancy loss are genetic abnormalities. As Dr. Surrey alluded to, as women get older, there's a greater chance when they release an egg that that egg is going to be chromosomally abnormal. And either it has too many or too few chromosomes. And when the sperm come in and the embryo now has too many or too few chromosomes, and our term for that is aneuploidy. Aneuploid embryos either won't implant, or if they do, they're going to miscarry early. That tends to be age-related primarily, rising more exponentially after age 35. However, some people have chromosomal conditions called translocations, where one arm of a chromosome is broken off and attached to a different one. So you have all the right stuff, but when eggs and sperm are being formed, they get kind of confused in their formation process, and you're more prone than you would expect purely based upon your age to form either chromosomally bad eggs or bad sperm. So there's genetic issues. And finally, what's the last thing?
Well, actually, Dr. Nelson, this might be a good time
to
ask
quit?
Alisa, because people are asking about complementary medicines or techniques, and maybe you can think about your fifth point, and also if there's complementary medicine. But certainly, people are asking about foods. What can you eat to optimize yourself so that maybe miscarriage is less of a factor?
Well, I would say one of the other interesting things that we've seen certainly in the decade of my practice is women with idiopathic infertility, so no known cause, no functional cause. And when we actually start to manipulate the diet by creating a more hypoallergenic internal state, especially in the large intestine, small intestine, reducing foods that are inflammatory, that increase levels of histamines and C-reactive protein, that in fact helps the body send signals to the brain that is talking to the ovary about timing for pregnancy being okay. And we were talking about internal levels of stress that the brain-body conversation is registering. And food, if it is toxic to your body, for example, a lot of women are gluten intolerant without realizing it, right? So you may not be celiac, but you may be sensitive to gluten, and continuously taking that into your small intestine creates a level of inflammation that starts to send signals of internal stress to the brain, which then, this is the hypothalamus pituitary conversation is cascading through all the target glands of the endocrine system and ultimately affecting how reproductively healthy you will be. So your diet has a very powerful net result in terms of what your underlying platform will be for reproductive wellness. So one of those things that you can remove immediately would be gluten-based products, so anything that is wheat-based. Another thing would be dairy products. We've seen a lot of women respond dramatically in terms of their estrogen-progesterone balance by eliminating dramatically their dairy consumption. And then, of course, environmental factors. There are so many products that we're using on our skin in our homes that create endocrine disruptive environments for our bodies as a whole. So being conscious of the things that you can remove from your skincare routine or your cleaning routine at home that may be inadvertently affecting your reproduction in a negative way would be a great thing to do as well.
So I'll just give you one more question. Liz, you can aim this at whoever you think is best to answer it. But does IVF increase the chance of ectopic pregnancy?
think it was,
Does
the question is, does IVF increase the chances of ectopic
Yes,
pregnancy?
exactly.
That's a very good question, but it again depends upon for whom. In so much as that there are abnormalities of the fallopian tubes, which either naturally or with IVF will be associated with an increased rate of ectopic pregnancies. And, you know, the reason why ectopic pregnancies usually occur is because the normal mechanism by which the fallopian tube transports an embryo into the uterus are deficient. They're lacking. There's something wrong. You know, so the same thing is the case in patients who have pregnancies from IVF, but they're controlled a little more with IVF because we're actually doing an embryo transfer that should be into a certain part of the uterus. So there are two answers to that question that could make it more relevant. One is that is there an underlying problem with the fallopian tube? For example, there's a condition called a hydrosalpinx, where the fallopian tube is closed at the end and open at its insertion into the uterus. So if you put an embryo into the uterus in a patient who has a hydrosalpinx, not only will she conceive less often, but she'll have a much higher incidence of ectopic pregnancy because that swollen, closed fallopian tube will change the way in which the tube works and will almost act as a suction where the embryo can be attracted to that fluid, and there'll be a higher incidence of ectopic pregnancy. The embryo transfer itself is a very interesting part of what we do, and it's probably one of the more sort of subjective and less studied and evaluated parts of what we do. But we've found that the highest rates of intrauterine pregnancies occur when we utilize a specific part of the uterus that's sort of in the middle of the endometrial cavity, if you think about it as a triangle. And if you deviate from that and you place the embryo closer to where the tube is inserted, which would be in one of the corners of the triangle, instead of the middle of the triangle, that may increase the chances of an ectopic pregnancy, particularly in patients who have an underlying dysfunction of the fallopian tube to begin with. So, again, it's a long way of saying sometimes it will. So it depends on upon the individual. But in order for a patient to undergo an IVF treatment, it's been pretty well established that if they have an underlying disease involving something called the hydrosalpinx, that should be corrected before doing an embryo transfer for that specific reason, to decrease the incidence of ectopic pregnancy.
Thank you so much. We'd love to be able to spend the entire day and answer everyone's questions. We will be walking around and in the exhibit hall. So again, I urge you to walk that exhibit hall, ask your questions, ask questions of our professionals here. I wanted to thank Unify and Maylene for sponsoring the session and making it available. I wanted to thank everybody personally for coming here and visiting, our panelists for participating and answering questions. And again, to our online viewers, please continue your conversations, feedback via Facebook and Twitter. Everything, all the programs that you are seeing here will be available online, so you can go and continue to view. And again, enjoy your time at the rest of the conference and ask questions and become empowered. That's the thing to do. Thank you.